Uh, our last speaker is Professor Andrew Horne from UK, Professor of Gynecology and Reproductive Science, Director of Center for Reproductive Health from Edinburgh. He will address us today about uh, another aspect of endometriosis, new avenues for the treatment of endometriosis associated pain. Professor Andrew, please.
So thank you very much indeed for the introduction, and a big thank you to Professor Gamal Samour and to the Society for the invitation to come and speak to you today. This is my first time in Egypt and Cairo, so it's a double pleasure to be here. So as you've heard, I'm from Edinburgh in the UK, and I direct the Centre for Reproductive Health there. These are my potential conflicts of interest. So we've heard very nicely from Professor Marcelin about endometriosis and the impact that it can have. And I want to talk to you about some of the work that we've been doing in Edinburgh, trying to improve the treatment, particularly of endometriosis-associated pain. Around 10 years ago now, I set up an endometriosis research group called Expect in Edinburgh. And we've set up this, if you like, research pipeline to try and approach the problem of improving endometriosis management. So to start with, we looked at the priorities of patients and clinicians in terms of what they felt were needed in terms of improving the management of pain. And we published a research priority setting result in 2017. And we've used these research priorities really to influence and to guide our research. We set up a patient sample database, a large tissue resource. We've been collecting samples from over 500 patients at the time of surgery. And from these patients, we collect obviously clinical information, but we also collect samples such as blood, urine, biopsies of their endometriosis, biopsies of the peritoneum, and peritoneal fluid. We've also been performing studies to look more longitudinally at the behavior of patients with endometriosis. The Endotech study shown here is using smartwatch technology to monitor, for example, sleep patterns and physical activity. The EndoFlare and the EndoGut studies are looking at the microbiome. So we're collecting urine and feces samples from these patients. And in particular, we're interested in the impact of diet. We've also developed models for helping us to study new treatments for endometriosis. So we've developed what we call our lesion in a dish, which is this co-culture model of peritoneal mesothelial cells collected from patients and endometrial stromal cells, if you like to sort of mimic the interactions between these two cell types. And we've also developed a mouse model of endometriosis. This is a syngenic mouse model, so we induce menstruation in one mouse and then inject the menstrual tissue into the other mouse, and these mice spontaneously develop endometriosis lesions. And we're carrying out a number of more early clinical and later stage multi-center clinical trials to look at the management of endometriosis. The two studies here, the EPIC and the MAC-ENDO study, I'm going to talk to you about in more detail. The EPIC study is targeting lactate as a potential treatment for endometriosis, and the MAC-ENDO study is targeting macrophages as a potential new immunotherapy. We're also doing a study called EndoCan, which is looking at a cannabinoid derivative to manage endometriosis-associated pain, and we're carrying out a multi-center trial to look at the impact of surgery on the particular subtype of endometriosis, peritoneal disease, and this is a sham surgical trial, and we've just recruited our 367th patient out of 400. And then the REGAL study is a study to look at what is the best treatment for recurrent endometriosis, so we're comparing surgery against a GnRH agonist. So if I start with the EPIC studies, why did we decide to target lactate as a potential new treatment for endometriosis? Well, I think we're all aware of the old theory that endometriosis, particularly pelvic endometriosis, is likely influenced by retrograde menstruation. But of course, retrograde menstruation occurs in around 80 to 90% of people who menstruate. So why does that ectopic tissue stick, adhere, form its own blood and nerve supply? So we've been interested in looking at the changes in the peritoneal mesothelium, the cells lining the peritoneum, the soil, if you like, and how they can influence and how they help with the development and progression of the disease. And in order to do this, we use our tissue resource. So we looked at samples that we'd collected from biopsies of endometriosis lesions, peritoneal fluid, and also biopsies of the peritoneum adjacent and distal to the endometriosis lesions. And what we've shown is summarized in this cartoon here. So you've got the pelvic peritoneal mesothelial cells on the left-hand side, peritoneal fluid in the middle, and then the endometriosis lesion. And we've been looking at the metabolic activity in these cells. And what we've shown is that there's an abnormal metabolic phenotype, if you like, in the peritoneal mesothelial cells. You see an increase in the metabolic drivers of glycolysis, but most importantly, what you see is an increase in the production of lactate within the peritoneal fluid. And this lactate we've demonstrated is produced by the peritoneal mesothelial cells. Why is lactate important? Well, this is derived from many studies in cancer, and the production of lactate is really important and critical for mechanisms such as adhesion, invasion, and angiogenesis, all critically important for the development of an endometriosis lesion. So we wondered if we targeted lactate, could we alter the progression of endometriosis and treat the symptoms associated with it? And others have followed up on some of these studies as well. There are groups who've demonstrated that one of the enzymes important for lactate production is altered in endometriosis stromal cells, and other groups that have also observed this altered metabolic signature, if you like, in endometrial stromal cells from the endometrium. So in order to try and alter lactate, we wanted to go down what we call a repurposing route. So we wanted to look for drugs which were already available, had already been tested, and ideally were already safe, to try and accelerate this drug treatment approach into clinical practice. And so we looked for drugs that targeted lactate, which I've listed here, and we focused on a drug called dichlorastate, which has actually been used for over 20 years to treat rare metabolic disorders in children. It's given in rather high doses, which you can see here, and we were interested in giving a lower dose to see if we could alter lactate in patients with endometriosis and see what impact it would have on their endometriosis symptoms. Before we went to patients, we went to our lesion in a dish model. So just as a reminder, this is where we grow peritoneal mesothelial cells that we've isolated from patients with endometriosis across the bottom of, if you like, a test tube. And then in an insert, we grow endometrial stromal cells collected from the patient. And then we're able to add drug treatments to this model. So we added dichlorastate, and we looked at the impact on lactate production from the peritoneal mesothelial cells and the proliferation of the endometrial stromal cells. And what we were able to demonstrate in this model was that dichloroacetate reduced lactate production from the peritoneal mesothelial cells, and also importantly appeared to reduce endometrial stromal cell proliferation. So this suggested that it might have an impact on the lesions themselves and reduce the lesions. So we then went to our animal model. So as a reminder, this is a syngenic mouse model of endometriosis. Mice don't menstruate, so we had to induce menstruation in one mouse and then inject the menstrual tissue into another mouse to allow it to spontaneously develop lesions. And we gave the mice with induced endometriosis oral dichloroacetate, and then we looked at the impact on their lesions. And what you can see here is that the mice with dichloroacetate compared to the mice given a control substance had a reduction in the volume, the burden of the disease of their endometriosis. So we're very excited by this observation in both our in vitro and our animal model of the condition. So the next step was to carry out a clinical trial, and this was a small study. It was a single-arm, open-label study, so it's important to bear that in mind when you see the results. If you want further details, you can scan the QR code. What we were doing was we were targeting patients with known superficial peritoneal endometriosis that were coming to our clinics. We were aiming to recruit just 30 participants, and the participants entered the study. They completed pain scores and then quality of life questionnaires, including the EHP30 endometriosis condition-specific questionnaire. And then they were given a 6-week treatment of oral dichloroacetate, and they were allowed to increase the dose after 6 weeks if they felt it hadn't been of sufficient benefit, or they could stay on the same dose or stop the dose if they had side effects. So the majority of the patients stayed on treatment for 12 weeks, and you can see that at midway and at the end, we also got them to complete the pain scores and the quality of life questionnaires. And because this was a small exploratory study, our primary outcome measure was recruitment and retention. Now, we unfortunately started this study midway through the COVID pandemic. So as you can imagine, that had a big impact on our ability to recruit and lengthened the study somewhat considerably. I don't know if it was the same for you, but we had to stop recruiting to clinical trials unless they were cancer or COVID trials for a large period of time during the pandemic. But we did succeed with our primary outcome measure, and we did manage to recruit and retain sufficient patients in the study to feel that we could move it forward. And we did look at efficacy, but again, bear in mind this is a single-arm, open-label study, so both the patients and the clinicians are aware that they're taking the treatment drug. But what was interesting was that we found that pain scores improved by an average of 2 out of 10 on the 0 to 10 rating scale that we were using. EHP30 scores, so that's the condition-specific quality of life questionnaire for endometriosis, reduced by around 50%. But I think what's really interesting is that 2/3 of the participants reported using significantly less pain medication at the end of the trial, and a number of patients reported taking the treatment as life-changing, having a huge impact upon both their pain and their quality of life. There weren't any serious adverse events in the trial, nothing to worry in terms of safety, but patients did have side effects quite commonly, and you can see these side effects listed here, some of them quite minor side effects. But the side effects that we picked up on was that around 54% of them had developed some intermittent tingling or numbness in their fingers. And if we look in more detail at the patients that had the numbness or tingling in their fingers and arms, you can see that they had higher levels of dichloroacetate within their system. Importantly and interestingly, these symptoms completely resolved as soon as they stopped taking the dichloroacetate. Why is this important? Well, DCA is metabolized by an enzyme called GSTZ1, and there are a number of polymorphisms which lead to 2 functional groups of this enzyme, which means that some patients are slow metabolizers of DCA and some are fast metabolizers. So patients can be genotyped for us to be able to predict how they're going to respond to taking the treatment. And if you look in detail, and we're not going to go through this full table, at the patients who experience the tingling and numbness in their fingers and arms, you can see that a patient who's a fast metabolizer who completed the whole trial with few side effects had low levels of DCA, and you can see their genotyping shown here. Whereas patients that were genotyped to be slow metabolizers, you can see had much higher levels of DCA in their blood, and you can see they had this neuropathy. And in fact, these 2 patients felt that they had to discontinue the trial because of the side effects. So having got this early evidence of efficacy, but also this issue around side effects with the treatment, we got funding to do a further clinical trial. And this time, this is a randomized, placebo-controlled trial to evaluate dichloroacetate in the management of endometriosis-associated pain. Again, if you want more information about the trial, you can scan the QR codes shown here. And in this trial, the patients will have a screening period where we'll genotype them to determine whether or not they're fast or slow metabolizers. They'll be randomized to either the treatment, the dichloroacetate, or a matched control. And then the slow metabolizers will be given a much lower dose of dichloroacetate, and the fast metabolizers will start on a higher dose. And similar to the previous trial, they'll be able to increase the dose halfway through treatment or stay on the same dose. And we're going to, again, be using the same pain scores and pain questionnaires to assess the patients in this study. Of course, the challenge we have with assessing a potentially disease-modifying drug like dichloroacetate in patients is that we can't do as we do in the mice and look at the impact on the endometriosis itself. We have to rely on patient-reported outcomes. Our target for this trial is to recruit 100 participants, and we're going to be recruiting in Edinburgh and London and starting this study next year. So for the second piece of work, the MacEndo studies, this is where we're targeting macrophages to treat endometriosis. And again, you might ask why we're targeting an immune cell and what is its potential role in the development of the disease. Well, we've shown that macrophages are abundant in lesions and peritoneal fluid. We've shown in an animal model that they promote lesion growth and vascularization. And we've also shown in animals that they're important in the development of pain symptoms. And in endometriosis, they exist in a different phenotype, in a pro-repair phenotype. So they, if you like, allow the endometriosis to stay alive, as it were, within the patient. And endometriosis macrophages are actually very similar to the macrophages that you see in tumors in cancer. And similarly, tumor-associated macrophages also promote tumor growth and inhibit phagocytosis. There are subpopulations that exist across a continuum, and they mediate phagocytosis to enhance clearance. And the important thing for us is that there are multiple anti-cancer strategies that involve macrophage repolarization. So we've been working with a group in the States who have a drug called RRX-001, which has been tested in anti-cancer trials in around 400 patients in multiple phase 1 and phase 3 trials. And this targets macrophages. It works by having different activity in normoxic and hypoxic environments. And you can see that it repolarizes the macrophages, enhances phagocytosis, and improves the vascularization around either the tumor or, in this case, the endometriosis. So together with a collaborator of mine in Warwick, Erin Greaves, we've been looking at the impact of RRX-001 on endometriosis in the same mouse model of endometriosis. This time we've labeled the endometriosis, so you can see the control. The endometriosis is shown in the red here in the mice. So you can see these mice were given match control. These mice were given RRX-001. You can see the dramatic effect it has on the disease. So really reducing the number of disease, reducing the volume of the disease. And interestingly, in this model, we looked at evoked pain-like responses. So we applied a von Frey filament to the abdomen of the mice. And you can see that treatment with RRX-001 also impacts upon the pain that these mice experience with the disease. So we're now just about to start a clinical trial again next year. We've got these 2 trials starting in the spring of next year. And this is, again, a very small clinical trial. It is a randomized placebo-controlled trial, but only 36 patients, partly because we're really keen to see how these patients tolerate this treatment. So we'll be giving it in gradated doses. So the first 9 patients will receive 2 milligrams, the next 9, 4 milligrams, the next 8 milligrams. And this is a big ask for patients because it's an immunotherapy that's given in an infusion over a 2-hour period, and they come for the infusion every week for 6 weeks, as you can see here. So in this study, we're really wanting to see how patients respond to having a treatment like this. We'll be looking at, obviously, safety, as well as pain scores, quality of life scores, and analgesic use. We've also got an embedded mechanistic study in this trial where we'll be looking at the impact of the drug on the endometrium, because obviously we're very interested upon its impact upon fertility. But we're very excited about this treatment because it's the first time an immunotherapy treatment has been used to try and manage endometriosis. I'm just going to finish with a final project which we just launched a couple of weeks ago in Edinburgh. And this is a UK-wide project. And this is, again, to try and improve the way that we care for patients with endometriosis, really looking at the existing treatments that patients are being offered and looking at self-management strategies such as change in diet. And this is called the Endo 1000 project. It's coupled with an awareness campaign called Talk Endo. We need to talk about endometriosis. So we're trying to use the project to help better educate the public and clinicians about endometriosis. So we've got a large social media campaign, and we've got a number of both celebrity ambassadors and if you like, normal individuals with endometriosis who are promoting the project and the campaign. And in the project, we're aiming to recruit 1,000 individuals with endometriosis and very carefully monitor them over a period of at least 2 years. During this time, they'll be asked to document their symptoms on a bespoke Endo 1000 app, their behaviors, any treatments that they have, including self-management strategies. They'll be asked to wear smartwatches so that we can monitor their sleep patterns and their physical activity. And we'll be getting them to collect biological samples of blood for their inflammatory profiles, saliva for their genetics, urine and feces to look at their microbiome and their metabolome. And they'll be collecting these samples in their own home, so this will be an entirely remotely delivered project. And the aim is that we'll collect a large biosource of data and biological samples, which we'll interpret, and then using machine learning and AI, we'll potentially be able to identify patterns that will help us better diagnose and more quickly diagnose endometriosis, but importantly, be able to predict which are the best surgical, medical, and self-management treatments for endometriosis. So we're, again, very excited about this project moving forward. So I'll just finish there in the interest of time and just acknowledge my team. This is us at the World Endometriosis Society Congress in Edinburgh last year. I'd really like to invite, I'm sorry I don't have a slide like Professor Marsland, but to the World Congress in Endometriosis, which is in Sydney in May this year, so you're very welcome to attend that. And as well as thanking my team, I'd like to thank our PhD students, my collaborators, my sponsors and funders, and also the patients who support our work. So thank you very much.